We're discussing diversity in health data, achieving benefit for all. The hashtag for the event is Our Future Health, and this panel discussion is taking place thanks to the generous support of Our Future Health. I'm Sarah Norcross, Director of PET, and I'll be chairing the discussion. This discussion that we're having is the second of three in a series looking at large-scale biomedical databases and research resources that PET is producing in conjunction with Our Future Health. Now, unfortunately, not everyone stands to benefit from advances in genomics research. Research databases and biobanks are made up of data from populations often labelled as European ancestry, limiting the utility of research findings using this data. The research using these mostly European databases is less likely to produce results that are meaningfully transferable to other populations. Now, for those of us familiar with travelling on the London Underground, we're used to announcements to mind the gap. And perhaps in the field of genomics, the slogan should be mind the diversity gap. So we're going to be discussing the case for seeking to represent a wide range of human genomic diversity in genomic data and how best to ensure that people from diverse ancestries and with lower incomes are adequately represented. And the questions that we'll be exploring in this discussion include: what have been the reasons historically for a lack of diversity in genomic data? What are the potential benefits of diverse data, both for traditionally underrepresented participants and for participants in general? And how do we know this? What steps have been taken to encourage recruitment from underrepresented groups, and what more might be done? And how can information about our future health be made accessible and comprehensible to all, or at least to as many people as possible? And how can our future health maintain and build trust among diverse communities? So it gives me great pleasure now to introduce tonight's first speaker, Anika Ladva. Anika is Head of Community Engagement at Our Future Health, and she works on initiatives including Our Future Health Pop-Up Clinic Pilot Scheme. That's quite a tongue twister. I wonder if she can trot it out really easily. I struggled with that when I was practicing. Now, previously, Anika was Senior Manager at Cancer Research UK, where she worked on community health engagement and partnership strategy.
So for my section of today's session, I'll be talking around what Our Future Health are doing to achieve diversity in data. And I know that Rahib, our CEO, covered the program and its aims in detail at the last, or one of the first sessions. But in case there are any new faces, I thought it would be really helpful just to do a really brief overview about Our Future Health and what we do. So we are the UK's largest health research program, and we aim to recruit 5 million volunteers, which is around 1 in 10 of the adult population in the UK, to build one of the most detailed pictures we've ever had of our health. And in terms of the aims of the program, we are building a resource to facilitate discovery and translational research by academic, charity, and commercial researchers. We are looking to provide personal disease risk information to participants, and we're also working hard to recontact participants to take part of clinical trials in the future. And Our Future Health is designed to help people to live healthier lives for longer. And by spotting patterns and signs of disease earlier, we can develop more effective ways to prevent, detect, and treat diseases. And just to give a really quick run through of what our recruitment pathway looks like, we are working in partnership with NHS to send invitation letters out to individuals who are over the age of 18 and live near one of our clinics. Once somebody receives their invite, they will click through to our website and they'll be given lots of information about what's involved and what and how they can take part, and they will then register and consent. And then in order to become a full participant, they need to complete a health questionnaire and also attend one of our appointments at a local clinic where they'll give physical measurements and a blood sample. And it's also one thing to note that when giving consent, participants are also agreeing to provide access to their health record and for us to recontact them for further relevant studies. So as of last week, this is the number of people that are already taking part in our Future Health, which is absolutely incredible. And so our Future Health is already the world's largest health research program of its kind, and it's a fantastic achievement in record time. However, size alone isn't enough. So we are very much set out to build a resource that truly reflects the UK population so that we can understand how diseases begin and progress in different people from different communities and essentially help everyone live longer, healthier lives. Because the fact is, many groups have historically been underrepresented in research, and this includes people from Black, Asian, and other ethnically diverse communities, lower socioeconomic groups, some people from certain geographic regions across the UK, and also specific age ranges. And these are also the people or the groups that often experience the worst health outcomes. So, for example, we know that individuals in lower socioeconomic groups have shorter healthy life expectancy. We know that Black men are more likely to get prostate cancer. We know that South Asian people face higher risks of heart disease and diabetes. So in order to have a maximum impact, we're really focusing on building a resource that reflects the UK population as a whole. And so the more communities that join our Future Health, the more discoveries we can make for everyone, which nicely brings me on to the topic for today. So from the outset, we have designed our Future Health to achieve diversity in data. It's very much been the heart of what we do as an organization. And we've always taken a test and learn approach. So, we know that there's no golden bullet. And what we do is we will gain feedback and insights from the communities that we are trying to engage with and trying to recruit from. And from that, we will then design and deliver small scale pilots to understand what works, what doesn't work. And with all of this, we will do it with feasibility and scalability in mind. So just to talk about a few things that we have done in the past and have are exploring to roll out wider or have already done so, we have launched clinics in regions where there is higher diversity, and we kept them open to maximize participation. Secondly, reimbursement. So we introduced a £10 voucher to cover some of the costs when it comes to participation to really help reduce those practical barriers that people face. And then just sticking with the practical barrier theme, I'll next talk about walk-in clinics. So we have developed a new enrollment journey, which allows people to join the program without needing to pre-book an appointment, because what we were hearing from certain communities is that they weren't actually finding the pre-booking of an appointment convenient. So that is something that we recently piloted. We have also focused on engaging with communities in different ways to raise awareness and build trust. And that's always looked different depending on the community that we're trying to engage with. And then finally, we've always made sure that our communications about the program have been designed with the broadest possible, that work for the broadest audience possible. So in terms of how things are going, we have seen that when we put things like this in place, it has had a positive impact on the diversity of the cohort. So we have more people from lower socioeconomic groups than any other UK health research programme, with currently over 10% of our volunteers from the most deprived segment of society. We are already the we are already the most ethnically diverse large-scale health research program in the UK as well. So roughly around the 10% mark, with the cohort being ethnically diverse, and almost 20% of our cohort is under the age of 40. And we also have people joining the program at clinics across England, Scotland, and Wales. And we are currently have plans to open clinics in Northern Ireland by the end of this year. So So that's really going to ensure that we've got coverage across the 4 nations. And over the last 5 years, we've listened, we've tested things, and we've adapted. And there's a lot that we've learned, but of course, not enough time to cover that all today. So here are a few nuggets. Um, Firstly, creating awareness, sharing information, answering questions, and demonstrating trustworthiness is really important. So, we saw this when we delivered our walking clinic recently. So, we had a number of staff on the ground to talk people through who we are, what we're doing, why it's important, and to help them through the journey if they were interested to join. And we had a lot of questions from people with from diverse communities. We also saw that some conversations lasted for over half an hour, but it was really important to us that people had the information and felt empowered to make that informed decision. And we really saw a difference in the type of people that were joining the program via a walking clinic. Having a multi-layered approach to engaging and recruiting members of underrepresented communities really does help overcome different barriers that people experience. So we know that there's no one-size-fits-all approach. And what we've seen is that when we layer initiatives, it very much increases our chances of actually being able to reach different types of people in ways that work best for them. The third point is that when we remove practical barriers to participation, we have seen that it enables people from younger, more socioeconomically deprived and ethnic backgrounds to join the program. So, for example, with reimbursement, it did have a positive effect to participation on the whole. However, what we actually saw, which was really interesting, is that the uplift was much greater from the communities that we're trying to engage with. And so we fully rolled out reimbursement, and we've continued to see the positive effect from that. And then similarly with the walking clinic, there is early indication. So although we're currently still in piloting this model, there's early indication that more diverse communities are joining via a walk-in route as they found it more convenient. But there is a lot more for us to learn before we roll this out wider. So we're actually delivering a second phase of that pilot, which starts this month. But from the first phase of the pilot, we also learned that 58% of those that we successfully recruited via the walk-in model would not have joined our Future Health had a walk-in clinic opportunity not been there present in their community when they were there. So that was really interesting for us to hear. And then finally, engaging directly with communities and designing communications that meets their need really works. So community engagement very much increases the likelihood of taking part when invited. And what we did is we ran clinics where there was no community engagement versus where we ran social media campaigns, where we engaged with community leaders and local businesses, and even delivered sort of smaller initiatives like chai and chat sessions with members of the public. And we saw a sort of a sizable difference when we did the community engagement work versus when we didn't. But that all being said, we know that this is a challenging space and there's always more work to be done. So, for example, when looking at the ethnic diversity of our Future Health cohort, there are some communities that are representative of the total population share, such as the Indian and Chinese communities. However, the numbers are much lower in other communities, such as Bangladeshi, Pakistani, Black African, and Black Caribbean communities. So what are we doing with that and what is next? What we've done is we've recently taken everything that we've learned and we are now focusing on 2 main goals to really make sure that we've got a much more focused approach moving forward. So in terms of those goals, firstly, we're going to be building a diverse cohort through smarter recruitment. And the second goal is sustaining that diversity in future studies through continued engagement. So to do this, we are prioritizing 3 areas. One is around enhancing awareness and relevance. So we know that diverse communities are less likely to engage with health research, and we can address this by raising awareness and communicating the program in a more relatable way. So we are going to be more focused on explaining our mission more clearly. So really focusing on the what, the why, and the how. We're going to make sure that we continue to tailor our message to different communities, and we're also going to increasingly work with trusted voices in the community as well. Secondly, make participation easier. So we understand that there are a lot of practical barriers to participation, and we need to take action to reduce these where possible. So we are going to focus on going to the communities that we want to reach rather than expecting them to come to us. And we're also going to focus more on simplifying our information so that it's easier to absorb and easier to understand. And then thirdly, strengthen community connections. So we need to really make sure that we're developing and maintaining genuine two-way relationships with underrepresented communities. So we are going to be more focused on listening to feedback and then acting on it, and sort of demonstrating that, but also demonstrating trustworthiness by being consistent, transparent, and being a lot more responsive. So I'll wrap up there, but I guess the last thing that I'll say is that our future health really does have the scale, ambition, and commitment to lead a new standard for diversity in health research. And we're doing it so that future discoveries reflect and benefit the whole population. So we are very much going to be focusing on learning. We're going to keep adapting. We'll keep sharing what we find in order to support other health research programs, and together we can ensure that everyone has the chance to lead longer, healthier lives.
Our next speaker is Sasha Henriques. Sasha is a researcher at Wellcome Connecting Science and at the Wellcome Sanger Institute, where she's exploring structural inequalities in genomic research. Sasha is a principal genetic counsellor at Guy's and St Thomas's NHS Foundation Trust, and she's vice chair of the committee of the Association of Genetic Nurses and Counsellors. She's a busy lady.
So as Sarah mentioned, I'm doing some PhD research to look at some of these structural changes around what we do with data and how we classify data. Essentially, that's kind of what most of my work has been about. I am in the very final stages of writing this work up, so I'm very tired. And I'm very close to submission. But I hope having a little chat about some of the things that I've been thinking about along the way will be a valuable contribution to this discussion and kind of widen out some of the thinking that we have when we think about that diversity gap that, that Sarah mentioned. So as Sarah told you, I am based at Cambridge University, and my PhD is with Wellcome Connecting Science, which is part of the Sanger Institute, and also sits under the Kavli Centre for Ethics, Science and the Public. So my work was essentially an ethnographic study, which I will talk about a little bit more on this campus of Sanger. And the reason that I kind of came to this question is part of the background of who I am. So I'm a genetic counsellor. I saw patients for many years, and so I was kind of really at the coalface of what these gaps in data diversity actually mean. So when patients come to your clinic, what is the understanding and the outcome that they get from genetic information that might be different based on which population they're from and whether that population is represented in databases. So one of the really interesting things about doing this work is when I started, one of the things that's quoted a lot is this paper where there is a monitor of genomic-wide studies and looking at the gap in kind of that diversity gap that we spoke about, that there is this overwhelming bias of European labeled data in the databases and in the work that we do. And so this very early on, kind of looking at it, there was this gap. And over the 3.5 years of doing the PhD, this problem didn't go away. And in fact, actually, when you look at the bias in data, when you look at studies globally, this problem seems like it got bigger. And so there are still these great campaigns like Our Future Health that are recruiting increasingly diverse data. But actually, when we look at what's being done with the data, these gaps actually aren't going away at the rate that we would expect them to, and sometimes they're widening out. So my question was about, like, where does that come from? Why does that happen? So why can we increase the amount of diverse data samples that we have, but actually we're still seeing this gap in the type of data that we're using to work out what genes do and work out people's health and the benefit that they can get from it? So some of the reasons behind why we see this gap are to do with kind of practical and methodological things. So the way that you label groups, the way that you decide that one group is one population and another is different between different studies. And there are also biases about what scientists might use as a data set. So because there is this historical bias in European data, sometimes people choose European data sets because they have the best power or because they're carried out in institutions that have the best reputation. So all of these things are actually, when you monitor, sometimes studies are entered in once or twice or many times into these diversity kind of monitors. And so actually what we're seeing is not just the gap, but also we're seeing the bias in what data is being used despite more diverse data being recruited. So those are really important questions that kind of came to me at the beginning. And so for me to kind of tease apart what I was actually talking about is this really important thing that I want to get across always, is that we're talking about diversity in lots of different dimensions. And sometimes when we think about the ethical dilemma of diverse data, we just think about recruiting more people into studies and then the problem will go away. But actually, it's a multifaceted problem. When we're talking about collecting the data and how we use the data, we have to think about diversity across many spectrums of kind of the research world and how the research world turns into that clinical world where I was seeing patients. So we have to think about who are the workforce, like who collects the data, who can ask the questions, and the bias in diversity that we see in the data is replicated in the bias in the workforce and the institutions that we see doing the work. So those are one of the types of questions that we can ask about where these biases and these gaps come from. And then we have this solid question that is about, how do we address this data diversity? How do we encourage different populations to be included? And how do we build capacity so that we are collecting data from around the world in populations and communities where we haven't historically done those for various reasons? And then this question, which I kind of felt was mostly my focus, that even if we had all of the data from all of the people in the world, the way that we group that data, draw lines in that data, decide which bit of data we're using and what bit of data we're not using, can also feed into this gap, this diversity gap that we're seeing. We're almost creating a diversity gap, even though we've got the data available. And so that's kind of mostly what my work was about. Like, how do I contend with that conversation? And the reason that I thought it was important is because there was this other thing that sometimes I feel like equity becomes a bit of a hot potato. That when you sit in the clinic, everyone's like, oh, it's the databases that are not diverse. And then when you speak to the researchers, they're like, oh, it's because people don't know how to engage with the patients at the clinical phase and, they don't trust us and they're not coming to the studies. So how was I thinking theoretically about tying that all together and having a fundamental thinking about what we mean when we say social justice in terms of diversity in genetics, something that's a seamless conversation about this whole process rather than just planting it in one space or the other. And I thought that the best way to do that was do a bit of an ethnographic study with researchers. So I had my positionality as a genetic counselor and what I know from engaging with the public, but also I wanted to have a kind of really in-depth understanding of how researchers are tackling these issues, how they are making the decisions about how they classify and categorize data. And so my study was an ethnographic study at Sanger. I had interviews with quite senior group leaders and scientists. I did observations of the scientific world. I also had interactions in kind of public spaces along the way to kind of ground this conversation that I was kind of having in two ways. And also I looked at a lot of the documents that were produced along the time that I was doing this ethnographic study. So when you look at a lot of the literature, it talks about this diversity gap for a long time. It talks about this bias for a long time. And I was like, so how is the discussion different now in the publications that we have? And so one of the things that I came to was kind of this concept of like dimensions and labels. And I had gone to a meeting where we were talking about genomics and ethics. And we had this conversation over dinner where the word pudding meant different things for different people. And so for some people, if they were British or English, pudding, your pudding could be your apple crumble. But then when I was talking to people who were from Germany, it's a very specific dessert that is your pudding. It's this very kind of creamy, chocolatey thing. And a pudding is only ever a pudding. And then, if you think about other dishes that actually have pudding in the name, like sticky toffee pudding or Christmas pudding. And sometimes that's how I like to think about these concepts of race, ethnicity, and ancestry that are really crucial in terms of how we're thinking about recruiting and how we're using our data. Because the dimension might be one thing, but the label that we put on it might change the meaning of that dimension. So you might be thinking about genetic similarity, for instance, but actually you're using a label of genetic ancestry. You might say that you're trying to recruit ethnicity, but you're using words like black and white, which are actually racial labels. And so these can change the way that we use the data, but they can also change the interpretation that we get from the data as well. So I did some, as I said, there were kind of different ways of collecting this data. And one of the things that I found is that in genetics, talking about race sometimes can be quite problematic. And so saying that race is a social construct is sometimes where the conversation ends and not where the conversation begins. So all these other structural and systematic inequalities that actually come from racial groups rather than ethnic groups or ancestry groups sometimes don't get dealt with, even though these labels were actually used in quite complex and complicated ways in the current research and publications that we see today. And even when I spoke to scientists, sometimes they were told like not to use particular terms, and they actually didn't really fully understand the reasons why they should or should not use particular terms. I also spoke a lot to people about the ways that they made groups. So there were lots of these statistically ways of inferring groups and then assigning continental labels to these groups. So you'd gather a group using one particular label like ethnicity, and then you'd use a statistical measure like principal component point analysis and determine that this group was a particular population. But because of the statistics that you're using, you're essentially creating a group that doesn't represent the multi-dimensional nature of most people's ancestry, and people often kind of get left out of those groups. So if you have a mixed ancestry or ancestry from more than one place, then these types of statistics might not be the best type of statistics for involving you. And then we kind of have this hierarchy of terms that we use, that there was this feeling that if we're calling something a genetic ancestry, that somehow that's a more accurate term. But as I said, this term of genetic ancestry as a dimension actually wasn't the way that we were using the data or labeling the data. And so a almost kind of a false accuracy was sometimes put on data sets by labeling them by words of ancestry, but actually you use something different to recruit them. And so, as I said, this kind of tells us a lot about kind of who gets left out of groups. And most importantly, exclusion isn't always a bad thing. So I started to think about also, when do we want groups overrepresented? When do we want groups involved in data, and when do we not? I spoke already about concepts of diversity. And so what this kind of all really drew me to was thinking about this complex kind of interactions of groups and scientists really kind of struggling and not quite understanding when they use particular groups and when they don't, and what the limitations of their statistics were. They also spoke about recruitment. They're not able in their funding to be able to do the recruitment, to get the data diversity to do their project. So this assignment, as I said, this hot potato of where the idea of the equity is, like where the bottleneck or the stoppers are. But this really in-depth kind of exploration with scientists meant that I started to pick apart those questions and actually speak about when people have opportunities and when they have barriers, and what their power and autonomy is about those more granular questions about data diversity than just saying we just need more diverse data. When is the way that you share data actually something that you have power or autonomy over? The partners that you collaborate with, the ideas that you choose, how you behave ethically, and also this idea of actually being able to represent the data in a much more honest, truthful and nuanced way than just dividing us into these continental groups that actually were a lot more broad than that. And so actually scientists are the ones that have a huge amount of kind of power and autonomy about the type of statistics that we use to truly represent the fluid nature of all of our ancestral data. So this kind of led me to thinking about a framework that I will hopefully put together, and I am too nervous to share the framework yet with those recommendations. But some of the things that kind of underline that kind of the principles of social justice that I wanted to be embedded in a framework, because we have lots of guidelines about what labels to use, guidelines about how to engage, but how are we actually kind of empowering people to follow those guidelines, use those guidelines, ask for the extra time in the studies that they need to be able to do this work. So it's this idea that when we're thinking about social justice, it's not something that remains just in social science and outside of the laboratory. There are actually opportunities and ways to bring that into the statistical and practical things that scientists do. They need particular skills and understandings to be able to do that. So the skills of a socially just researcher are things that still need to be gathered. This idea of kind of interest convergence, which kind of comes from critical race theory, where minority groups get benefit when dominant groups kind of move forward. And we see that a lot kind of in data diversity. And how can we use that to benefit groups that have been underserved and underrepresented in the work that we do? And how do we scale up the type of work that I do, where I just spoke to a few scientists in kind of one institution? And really importantly, this idea that having these type of nuanced and ethical conversations with scientists is really empowering them to think more broadly about leading the way in rethinking how we define our populations. So we talk a lot of the time in genetics about harmonizing our data and reducing who we are, for a seamless kind of pot at the end of the rainbow type of being. And so this is kind of one of my favorite quotes from Peter Tosh, who's a reggae artist, and he has a song called Equal Rights. And so this kind of charging forward because you want peace, but without thinking about the justice beforehand, I think is really important.
Next, we have Professor Segun Fatumo, who is Professor and Chair of Genomic Diversity at Queen Mary, University of London's Precision Healthcare University Research Institute. He leads projects including Uganda Genome Resource and the Nigerian 100,000 Genome Project. Segun is co-editor of the book Health Technologies and Informatics Research and Developments.
Today, I'll be talking about why African genomes are the key to accurate genetic risk prediction. If you are very familiar with London, so this is how the ethnic diversity look like now in London, with a Black minority ethnic group contributing about 60%. That is much more than the white population in London. You have the Bangladeshi about 39%, in Whitechapel, and the white British about 24%, and Black about 4.4%. So this is showing how diverse we are in London, also across many places within the UK. So there's been evolution of medicine over the past year. So in the past, medicine was mainly by intuition. Presently, so medicine is not based on evidence. And we saw a lot of that during COVID. You hear a lot about clinical trial. So medicine is purely evidence-based. So now and in the future, so medicine is being practiced or will be practiced according to an algorithm that takes into consideration patient characteristics. This will include the patient's genome, epigenomics, lifestyle, which constitute what we call precision medicine. Here is an example. In this online meeting today, we are very different. So should our treatment also be different? Here on the left, I show an example of a patient population that show that we are really very different. And on the right here, I show the normal standard approach where one particular treatment is administered to that population. What always happens is that that treatment is only effective for about 20% of that population and become a waste in the remaining population of about 80%. But a much more tailored approach or precision approach is an approach where an appropriate treatment is given to the appropriate population. For example, a treatment A is given to, say, African ancestry individual, treatment B to South Asian individual, treatment C to East Asian individual, and treatment D to European ancestry individual. So with this kind of treatment, so it means that the right treatment is given to the right patient, and everybody is happy and living longer. Here's an example of a current medication from what we call PCSK inhibitor. So this medication is now used to lower cholesterol, to lower bad cholesterol. What I want to emphasize in this particular slide is the discovery of this particular medication is because some African ancestry individuals were included in a particular study. In that study, they found that those African individuals, they have some genetic variants that help them to naturally lower their cholesterol. So the emphasis is that if those African ancestry have not been included in that study, today we may not have this medication that is helping everybody, whether Africa or not Africa, to lower cholesterol and also help to prevent heart attack. So we are going to continue to do ourselves harms if genomic study is not diversified to include Africans and also other underrepresented population. I also want to give an example of why we need to diversify genomics. Here's a medication. If you have high blood pressure or hypertension, and you walk into a GP in London or anywhere in the UK or most of the world, so you are likely going to be prescribed ramiprine, which is a medication for lowering blood pressure. Unfortunately, this is not as effective as it is for white European population for African ancestry. So it's not as effective in African ancestry compared to white European. Of course, there are many other factors that contribute to that because of kidney disease in African ancestry. So here, an example again, why we need to study all population. So why is African genome so important? Because there have been multiple genetic studies that confirm the out of African theory. So meaning that about 60 to 100 years ago, the modern woman migrated out of Africa and they started to populate the whole world. So when they left Africa, they carried with them only a small part of the African genetic variation with them. So that means that there's more genetic diversity in Africa than other populations. What is even more interesting is that even within Africa, there is larger genetic differences within Africa than between African and European population or between Africa and the Asian population. Here's an example of what Sasha has talked about. In the second year, I mentioned Uganda, and then we collected samples from different locations in Uganda. One of them is UNS, one of them is UBS. You can see on the right here, the PCA, you can see how different these particular two settings in Uganda, how different they are. One is tending towards Central Africa and one is tending towards East Africa. This is how much diversity in this population. So what does it mean? What does this diversity, what does it mean? What is the implication of this diversity? So it helps us to understand the modern human evolution. It also helps us to find some variants that are yet to discover because there is more diversity within African population. It also means that genetic study in non-African population, including their clinical relevance, may not be generalizable to African population, including even within Africa. So it means that some finding from one subpopulation in Africa may not be transferable to another population within Africa. So there's a drastic lack of diversity in genomics despite repeated call. Here I show an example of what has been happening. In 2016, you see about 81% of genomic study are based on European ancestry individual, with only 3% in Africa. You go down to 3 years down the line in 2019, you see a decline in study from Africa from 3% to 2%, and back to 2022, further decline to 1%. So you see, we're not really doing very well in studying African ancestry individuals. What is even most unfortunate is that the 1.1% Africans in genomic study that I mentioned are mainly African American. So that means that they are not really covering the continental Africa. So if you continue to study a number of African in diaspora in African Americans, we are going and just group them together as African. What we are doing is broadening the genomic imbalance. Here is a commentary that we sent to Nature to emphasize that the African American genomes don't capture the African genetic diversity. And we give several examples, including an example from a study that studied about 5,200 North Americans of African descent. In that study, if you look at the individuals in that study, they are mainly people that originated from just one single region in West Africa. The common ancestry, like a Nilo-Sahara speaking people, Kosan or Tagara people that are extremely underrepresented in genomics. We need to remember that Africa is home to some individuals from 3,000 different ethnic groups and speaking more than 2,000 different languages. So in 2019, we conducted what is called the largest ever genome study in Africa, which was a sample that we collected from Uganda population. And in that study, we had about 2,000 people that we did the whole genome sequencing. We identified about 9.5 million novel variants, which is much more larger compared to if you do such study in European ancestry individuals. We also did a genetic association study for about 34 different cardiometabolic traits. We identified some novel variants. What I want to emphasize on this slide is the last two columns. The last column is the minor allelic frequency of European ancestry, and the one before that is the allelic frequency for African ancestry. So these variants, most of them are monomorphic, meaning that they are absent in the European ancestry individual. But these same variants are found to be novel in African population. Again, this emphasizes the need why we need to study all populations, including African population. So since then, we've been using that data to identify a subgroup of individuals that may be at high risk of cardiometabolic traits, including type 2 diabetes, lipid traits, and other complex heart disease. And I give an example. In this particular study, we developed genetic risk score using a range of data sets that are available. One from the multi-ancestry well-powered data set from 1.4 million people, and also a small data set from African ancestry, about 50,000 people, and European ancestry. Of course, you see here that the African ancestry data set is very small. So we're using this data set to see whether we can use that to predict diabetes in South Africa, and also validating Kenya, Nigeria, and Ghana. Yeah, the emphasis here is to say that we have the highest variance of R square from the genetic risk score that we developed from the African ancestry individuals. So that data set was available and is showing the best prediction for PRS. So if that is not available, that would not have been possible. So we also did a similar thing also for lipid traits, where we show here that the PRS that we developed from the African ancestry individuals, even though that sample is small, it's much more transferable and predicting better in continental Africa compared to the big data set from the multi-ancestry and European ancestry individuals. But what I want to emphasize here is, even though we are predicting better, so in this study, we also saw that we are predicting better in South African population, but predicting very poorly in the Uganda population. Again, this emphasizes the diversity even within Africa. So meaning that the findings from one particular study in one particular region may not actually be transferable to another region within Africa. So this study was published in Nature Medicine for those that are interested. So there are many factors that have been contributing to poor transferability of PRS in African population. One of them is the allelic frequency. One of them is the leaking disequilibrium, because the leaking disequilibrium in Africa is much more smaller compared to African population. There are also other interaction with environmental consideration, like the diet, what people eat, whether they exercise or not, age, gender. They also contribute to genetic risk scoring. Also, the variability in how different traits or different phenotypes, like a lipid trait, have been measured. So, given that Africa has the highest genetic diversity in the whole world, so the current lack of diversity in genomics have implication on the predictive power of all this method, because those methods have been mainly Eurocentric in the dataset that was used for the training. So as I conclude, here is showing there are now more data sets that are coming up from Africa, thanks to the initiative like the H3 Africa Initiative, the Nigeria 100,000 Genome Project, Ugandan Genome Program. So these data sets are going to be great value for discovery, for genetic prediction that can be more generalizable within the African population. So in order to achieve an accurate genetic risk prediction and transferability across all population within Africa and globally, so there is need for us to have large-scale African data set. They are necessary for PRS to actually achieve its potential.
Now, following on from Segun, we have our final panelist, Dr. Divya Shanmugam. And Divya is a researcher at Cornell Tech, developing data-efficient methods for reliable machine learning. Previously, she was a researcher at MIT's Computer Science and Artificial Intelligence Laboratory, and she has published research and commentary on topics including the use of generative AI in medicine and the relationship between race data and clinical risk scores.
I research the use of AI in healthcare, particularly as it intersects with health equity. So today I'm going to talk about what health equity has to do with data collection and how promoting health equity in machine learning often means collecting better data. And so here I'll be talking about data outside of genomics in the context of the electronic health record. And as a disclaimer, much of my work has been done in the context of the US, but I believe there are kind of broader lessons about health data across nations. Okay, so let's get started. So I wanted to start with a brief anecdote. So I, like many others, use ChatGPT to ask medical questions. And when ChatGPT came out with image generation capabilities in March, I wondered how this expertise translated to women's health. And so what I did is I asked it to generate an illustration of the anatomy of the female reproductive system. And this is the image that I got in response, which I think is a little bit fascinating and horrifying. So let's dig into what it says. Basically, according to ChatGPT, the female reproductive system contains 6 ovaries, 5 fallopian tubes, and 2 uteri, one nested inside the other. And of course, this doesn't represent the female reproductive system very well, and I'm sure there are some fertility experts in the audience who can confirm. And the reason we see this is that it's an interpolation of many different images the model has been trained on, and it fails to communicate useful health information. And I think this actually points to a broader challenge in using machine learning systems for healthcare, in that there are persistent gaps between the behavior we want out of these systems, things like clinical understanding and reasoning, and their actual behavior. And I should be clear, generative models have achieved fantastic results in certain domains, including answering questions for medical exams or diagnosing complex clinical cases. And so there's a lot of promise from these tools, but there are still areas in which they don't perform quite well. And I would say the reason that we see this is because much of these gaps in performance often have to do with the data that we use to train these models. And so I would argue that to build machine learning systems that serve all patients, we need to rethink data collection. And towards that end, I want to talk about 2 pieces of work that offer ideas about how to do this. And so I'm going to talk about 2 places in which data collection is very important to machine learning systems. First, in the data we use to train machine learning systems, and second, in data we use to evaluate machine learning systems. And so both of these projects are related to research that we've put out from our group. And so in the context of training machine learning systems, traditionally what people do is collect a set of examples, for example, symptoms from each patient, along with labels for those examples to teach the machine learning system what a patient with the disease looks like compared to a patient who doesn't have the disease. And so let's get started with this section. So the motivation for this work was the fact that diagnostic data is a cornerstone of clinical decision-making. It's used for treatment recommendation, they're used for developing prevalence estimates of different diseases, and finally, diagnoses are used in machine learning to train these models. But the fact is, not all patients with a disease end up with a diagnosis in the health record. And so this poses a risk to all these downstream systems and analyses that use this data. And so to address this challenge, what we did is we developed an approach to measure these hidden diagnoses of specifically atrial fibrillation using a longitudinal data set of ECGs. So I'll abstract away some of the details, but the idea with this work is to take, say we have these 2 patients with normal ECGs. What we do is we feed those ECGs into a model trained to predict a patient's risk of that condition. And then what we do is we compare diagnostic data across patients with the same estimated risk of that disease. So what that lets us do is to separate differences in diagnosis rates from differences in disease risk. And this will help us understand whether diagnosis quality differs between racial groups or other demographic groups. And in short, we find that Black patients and racial minorities in general are far less likely to receive a diagnosis of atrial fibrillation compared to white patients. And so what I'm showing you here on the x-axis is different risk quintiles. So different patients with the same estimated risk of the disease. And on the y-axis is diagnosis rates. And so what you can see is that at each risk quintile, white patients in blue have a higher diagnosis rate compared to group patients from other racial minorities. And this is despite the fact that conditional on risk, these groups experience the same rates of complications. So it's not that Black patients are healthier and receiving fewer diagnoses. They're of seemingly the same health and they're receiving fewer diagnoses. So what does this mean for machine learning and public health? It suggests that public health analyses that rely on diagnoses in atrial fibrillation underestimate the prevalence of disease among racial minorities. It also suggests that machine learning systems trained to predict these diagnoses will systematically underdiagnose racial minorities. And these are unfortunately not problems that we can solve by collecting more data, because the problem lies in how we're labeling these examples. And in the paper, what we do is we explore reasons for these disparities and we test the robustness of our findings. But the main thing I want you to take away from this is that there's strong evidence that health disparities shape the data that we collect. And as we collect more diverse data sets, we have to confront how structural inequalities are embedded within the data itself. In other words, diverse representation is a first and necessary step, but we also need to make sure that the data is equally accurate across racial groups. Moving on to the second project, now let's talk about how data is used to evaluate machine learning systems. And this work has a lot of connections to the earlier presentations, in particular what Sasha was mentioning on the arbitrariness of different groupings and how that can affect the validity of downstream analyses. Okay, so traditionally people measure algorithmic fairness, for example, whether performance of a model is similar across demographic subgroups, by using coarse race variables. In the US, these variables are often inherited from the census. So in our case, we often use Hispanic, Latino, Black, Asian, and white. And I've illustrated an example on the right. So here we're evaluating a machine learning model trained to predict a patient's risk of hospitalization. And each line indicates the AUPRC, which is a measure of performance in each group. So we can see that performance is highest among white patients and lowest among Hispanic or Latino patients. So in this work, what we asked is, what do we lose by using these coarse race variables? And what we find is that coarse race data conceals substantial disparities in clinical risk score performance among more granular subgroups. And so let's take a closer look at Asian patients. So Asian patients, this is of course a very broad category. It includes Japanese patients, Indian patients, Korean patients, etc. And so when we break out performance in terms of these subgroups, we see much larger variation. In fact, what we find is that there is even greater within group variation in performance compared to between group variation in performance, which suggests that analyses in algorithmic fairness have been limited by the use of coarse race data. So the concrete takeaway here is that we should strive to collect and report granular race data where possible, because releasing that type of data would allow us to better understand the strengths and weaknesses of machine learning systems. And I think that data sets so far have been making great progress towards this goal. For example, All of Us in the US has started to release granular race data. Another popular electronic health record data set among researchers is Mimic, which also releases granular race data. So I think we're making great progress towards this goal. So I'll close here. To summarize, machine learning systems that promote health equity require careful consideration of the data used to develop them. And I discussed two ideas for how we can center health equity in data collection. First, by treating observable health data as a proxy for patient health that's shaped by patterns of health access and diagnosis. And second, collecting and sharing more granular race data. And of course, these are just two ways in which data collection can be reworked in service of health equity. There's so many more parts of the health data ecosystem that one could reconsider. For example, how we obtain consent, or group-specific patterns of interaction with large language models or other health information interfaces. And so I think it's a really ripe area for future work, especially as more and more automated systems are deployed in service of patient health. And I'll close by thanking my collaborators, without whom this work would not be possible.
because I came at this work, I guess, as a clinician, but also using social science methods, one of the big leaps for me to make was understand it at a like statistical, mathematical level. But it seems as though I still kind of got to the same place. So I guess one of my questions is, as somebody who's working with the data and the science, I think that there's a big question about kind of bringing that ethical thinking to the data and the science. So what brought you there, and how do you think I should be communicating these findings so that we get scientists to think about their data work in this way?
Yeah, that's a great question. So I actually came to this question because of a data set release, and it was because I kind of saw that this information was newly available, and it felt like a new opportunity to make estimates of machine learning performance more precise. And I think I've always been puzzled by the use of, white and black categories alone to like kind of talk about disparities in algorithmic performance. Um, so yeah, that's kind of what brought me there. I think it was really spurred by the availability of data to even study this question,
Yeah.
which I think was amazing. I don't know if that fully answers your question. I think there was one other part that I
How should I then how am I going to talk about this therefore to people who are just like, Elsie's not what they do, ethics is not what they do, they're just doing
uh-huh.
data. Like, yeah, that question, I guess.
Yeah, no, I think that's a great question. I think yeah, I think that like often the feedback I get on this work is about like the statistical power involved with
Yeah,
smaller groups. And I think the fact is like that's kind of a secondary question. Like you should still be doing these analyses and making
sure.
the conclusions. And so I think coming at it from like how essential these findings are, regardless of statistical power, is maybe a useful way to
Okay.
communicate it to
Okay.
statistical people.
Yeah.
But yeah, I agree. I think people have long been satisfied with using very simple race categories to perform these
Yes.
analyses without thinking about what we might be missing and how we could even replace the race variable with something more accurate.
Yeah. What else could
So
we be doing? Yeah. Yeah.
yeah, I think one thing that came out from this piece of work was that country of origin
Hmm.
actually, has more of an indicator of patient health and performance
Yes. Yeah.
compared to race. And so which I think connects with a lot of what we've talked about so far. So
Yeah.
yeah,
Thank
I
you.
do think it's an opportunity to reimagine what we're doing.
Yeah. Thank you.
Mhm.
Great. So we've got lots of questions. So I'll start. Actually, as I can see that Shigumi is back, and I'm worried he might lose internet connection, I'm going to go with one for him first. Philandra Costello has asked, what factors encouraged or motivated people in Uganda to participate in the genomics research, and what lessons can be learned from there?
Oh, thanks. That's a great question. Thank you for that question. So there are many factors. One of them is that we are doing an appropriate community engagement, and I will explain what I mean by that. So community engagement is not a research announcement. What many people do is they just announce that they want to do a study to the community, and that is all. So community engagement is much more than that. You need to engage the participants long time before the study, during the study, after the study. We do all that even when there's no study ongoing. We engage the participants at different stages, and we also give them feedback of every single study that we do. If I give an example of one study that we did in 2011, when we took blood sample from people, we tested them for different kind of cardiometabolic disease. If people have high blood pressure or they have abnormal results, what do you do with them? Do you just leave them to go away? So we went ahead to support them. We have a clinic facility in the community where we support them. So that's one. So we do proper community engagement. Another one, which is most important, is trust. In the community that where we work in Uganda, we've been collecting samples in that community for 36 years. So they know us, they trust us. It's very different from many Black immigrants in the UK. because there's an issue of trust already at stake. And that is why many Africans, for example, are not going to participate in the study because there's issue of trust. There's a lot of misinformation out there. People are saying, don't take the vaccine because they're trying to depopulate the African and all non-African. These are some issues, and there are many other issues. I'm not going to go to that. Yes.
Did anybody else want to come in on that before I move on to the next one? So there's another one from Philandra actually, but it's the most popular. So she's getting two questions right at the start. And she asks, AI will become increasingly central to genomic analysis if most of the training data for genomic AI tools comes from white European populations. What implications might this have for our diverse patients, and what can we do about it? So perhaps Divya first, and then we'll see what everyone else thinks about that.
Yeah, this is a great question. I think we've seen the effects of this a little bit already in terms of like 23andMe, where predicting ancestry is much worse for certain populations compared to others. I think there are maybe two things that we should prioritize in light of this. First is, some of the amazing work that's already being done to collect more diverse genomic data sets. But also, I think we need more precise evaluations of these systems such that when clinicians or downstream users are using these tools, we understand where they work and where they don't. And so they're kind of being used on the right patient populations. And so I think that that's another part of the issue, but I agree it is kind of concerning, and we don't currently have like the tools, I think, to address it yet. I'm curious to hear what Sasha and Anika have to say too.
Sasha, do you want to come in on this?
Yeah, absolutely. I think a large part of what I hope I can help scientists do, as you said, is have funding being directed to the tools to be able to do these things. So I think I am constantly frustrated by the fact that like there is a problem and it needs scientific attention, but actually these are not the things that are prioritized in funding. So actually, everybody knows that there's a gap in diversity. So people like publish a paper and then they just say, oh, if we had a more diverse data sample, this would be better. Like that's all the limitation ever says. But we don't have an actual measurement for, well, actually, if we use this population, this is how it would be different. And there are scientists that I've spoken to that have put in proposals to do that work and it doesn't get funded. Something else gets funded that is more about a different type of collecting data. So, yeah, I don't think it's outside of the capability of bright minds like you. I just think that there is, something about people understanding that that's the thing that needs to happen. It just quite hasn't been said loud enough. So I will try and keep saying it loudly so you guys can do the work.
And Anika, did you want to come in?
I I haven't, so yeah, I don't know if I can really comment on this because I'm not I haven't there haven't been there are increasing conversations at Our Future Health about AI and sort of what that means, but I haven't been in any recently. I guess the one thing that there was a conversation about recently is sort of how can we identify and mitigate biases in AI models, and what does that look like? How does that mean? So I know that there is thinking that's currently going on about it, but I just, yeah, I don't have an answer for that, but it is a really interesting question.
The other thing I might add before we move on is sometimes in defense of AI, sometimes it's a comparison to current practice and not performance in like the majority group. And so sometimes even if performance is different between groups, this could be an advance on current clinical practice. So I think there is like a kind of trade-off in thinking about whether or not we should use these tools, even if there are disparities in performance, because it could be an improvement on what we're doing right now. So that's the last thing I wanted to say.
Segun, did you want to
Yes,
chip in too?
I can add to that. AI is just a tool. And in my undergraduate degree, what we're taught is garbage in, garbage out. So if we continue to train AI with one singular data set for European ancestry, it will not be useful for all the population. It will be useful for European ancestry. So we need to use AI in a way that we use data set that is more representative for all population. If you do that, AI will be useful for all population. So what has happened in the last few years in terms of genomics, we should try to not allow that to happen again. Because we have AI, it can be useful if you use the right data sets. But if you don't use the right data sets, it's not useful for all of us.
Thank you. I'm going to stick with you now, Segun. This is from someone who's chosen to be anonymous. They say, is it the case that because we all ultimately come out of Africa, and I did like the picture on your slide, genomic data from African populations is more generalizable to the rest of the world than genomic data from the rest of the world is generalizable to Africa? Or is it more the case that we need data to be more diverse so we don't have to generalize at all?
So I think I would say we need data to be more diverse. We all came from Africa, so it means that broadly speaking, the data architecture or genetic diversity that you see in other populations are largely a subset of what you see from African population. So meaning that every study that you do, there are still more to be discovered if you don't study that African population. I gave an example in my presentation about genetic risk score. What we've been doing in the last 10, 20 years is trying to develop a genetic risk score from European ancestry individuals because that is where data is available. What I think that we should be doing is developing genetic risk score from African population and test them in other population. But at the moment, we cannot do that because we don't have sufficient power data set from that population to test in other population. So we need much more diverse data set across all populations.
Great. Okay, does anyone else want to come in on that one before I move in? But I think he's covered it all really there. A question for Anika. How, if at all, are the issues of diversity and ancestry addressed in the written information that our Future Health gives to its prospective participants? These things are understood in many different ways by different people and communities. And then the relevant scientific facts are something different again. So I suppose it comes back to the layering. It's a whole nother layer of things to explain. So if you could give us a bit of detail on that.
So we haven't nailed this, as I mentioned earlier, we're very much still testing and learning, and it's no surprise that different communities want or appreciate information in different ways, whether that's face to face, whether that's via an animation, a video, imagery, etc. So we are still learning what the preferences are and what's the easiest way for us to communicate things in a really simple and understandable way. But in that sense, what we're doing at the moment and in the process of is starting to create more simplified, easy read assets. And we're going to be offering sort of a range of things, which sort of goes from easy read leaflets all the way through to animations, videos, and a lot more information, like sort of I guess somewhat a Q&A, but sort of developed in a certain way that lands better with different audiences. So we are in development of all that at the moment. But what we have found is that when we have asked the question of how they would like to understand, how different communities want to understand about our Future Health and sort of the research program that we have, a lot of them have said that they would prefer face-to-face and that they would prefer like sort of two-way conversations so that they can ask questions. Now, obviously, that's something that we try to do where possible, but it's not scalable. It's very costly. So we're trying to figure out what can we do that could work in that sense. So yeah, still working on it. I'm going to be testing different things, but it's just quite difficult for us at the moment, just because we're trying to come up with a range of offerings that work for different communities, but also thinking about feasibility, scalability, cost, and other things as well.
And then another question is genomics is complex. How are we ensuring that complex information is available for people with low literacy levels, digital poverty, because they obviously have an impact. So I think we'll go back to you first, Anika, on that, and then perhaps see if Sasha's got something to add on that from her experience.
Yeah, I mean, I guess the only additional thing that I will say is that we are, we are aware of the digital poverty element, and we have actually had people when we're out in the community asking if they can join, even though they don't have a smartphone or they don't have access or have limited access to the internet. And we are currently working on we offer a non-digital way for people to join, and that's something that the organisation is aware of, and it's hopefully something that we're going to look at in the future. There's nothing else to really add a lot, except for the things that I mentioned earlier in terms of like sort of having different ways to communicate different things to different audiences at the moment.
And Sasha, perhaps you can come in on this, perhaps from your experience as particularly as a
Yeah,
genetic counsellor, actually.
I was wondering if that was what you were asking. So, yes, very, very much so. Genetics is complicated, and I guess sometimes that's where I guess see the value of how we practice as genetic counsellors, that we absolutely do think very seriously about people's kind of literacy, numeracy, communication styles and skills, and have different ways of kind of talking about quite complex issues and using different resources to do that. I still think, however, we are particularly under-resourced in the NHS for having the right tools to be able to do that. And so we do rely very heavily on kind of charities and community organizations who can also kind of help with that kind of engagement and talking about like very specific issues that maybe kind of being in a genetic counselling situation isn't appropriate for. And there are kind of other groups that are very well aligned with genetic counsellors that are also able to have those conversations for people. So so it's a bit of a team effort, I think, being able to communicate these quite complex things to our population. Yeah.
And Divya, would you like to come in on this one?
I just wanted to mention there have been some promising results on using AI to improve patient understanding of various complex health information. And so there have been some promising evidence in that setting. I don't know if it's been applied to genetics yet, but it does seem like an opportunity for
I think there are a few things that people are using AI for, particularly because globally there just aren't that many genetic counselors, and there aren't like, so we complain about it in the UK, but when you think about it globally, most of the world just don't have genetic counselors. So actually AI has been really crucial, I guess, as well as kind of nurses on the ground and in local communities, but actually thinking about ways of using AI to do family history taking and thinking about communicating some quite simple genetic concepts. But as a genetic counselor, kind of the psychosocial aspect of having that conversation is still something that I will really kind of advocate for as well. So it's not just about the information, kind of just like you said, AI can't get that kind of nuance and granularity, and so that's really important as well. So building that capacity so that everybody has access to that, I think, is still really important as well.
Yeah, that's cool. Thanks for saying that.
And Shanmugam, you've been waiting patiently to come in.
I'll be very careful in using AI to explain genetics, particularly to people from Africa population. Let me just make it very basic. In Uganda, where I've done most of my work, I know we said genetic is complex, but it's very, very complex information for people in Africa because many terms that we use in genetics, like DNA, gene, genomics, there are no equivalent word for those in different African languages. And remember, when I was making my presentation, Africans speak more than 2,000 different languages. So if you go to a particular community where people speak, say, 5, 6 languages, so the first headache you have to think about is how do you communicate this to each of them in their own language? No, it's much more easier in the UK. Everybody speaks English, everybody understand English, at least what they're speaking. But in Uganda, for example, people speak diverse languages. So the first thing is to try to explain, do they understand what you mean by gene or what you mean by genomics or what you mean by DNA? I give an example in one study that we did, where we did a translation of our questionnaire to their local language. And we were very lucky that we also did a reverse translation. So when we did the reverse translation, we saw that some of those terms were not actually as accurate. People, if you didn't do reverse translation, you will know that the way they were translated were not actually accurate. So genomics is complex, but it's much more complex in settings where people speak 2,100 languages. So we have to find a way to break it down to them.
It just seems totally overwhelming. The scale of that challenge. I suppose it's chipping away one at a time. And that's and not to be overwhelmed. So I'm going to move on now to a question from Talmida Zaman. She's got two questions, one for Sasha, which I'll do first. So Sasha, she said, are there any legal requirements to separate out results from clinical studies by ancestry? And if not, how can we move towards that? Are there any attempts to standardize the ancestry label? So she's got two questions there for you. So
Okay, so no, there aren't any legal requirements. There are lots of guidelines about how I think the question is about avoiding misrepresentation, I guess, of results by separating out the ancestry from the research. So I guess there are, depending who you publish with, publishers might have guidelines, your genetic institution that you belong to might have guidelines, your professional institution might have guidelines, but I don't think there are any legal requirements. I think because we use these labels in censuses, we use them in clinicals, like we use them in so many different ways that there are no kind of legal standings about what these labels should be. Are there any attempts to standardize? I think so. I'm going to pick up another question that somebody also asked me, which was about not using racial terminology, because I think it's really important as part of this conversation about where my personal stance is on this, that I think sometimes because I talk about the fact that ancestry labels are limited, people might raise to me saying that possibly I don't use race, and I actually do, because I think that you can't talk about racial inequalities and you can't talk about systematic things and you can't talk about racism without understanding the social concept of race. And so when we think about the diversity of patients, there isn't just their genetic diversity, they're the ways they're experiencing the world. So that will be about geography and environment, and we spoke about place of birth, but that will also be about how they're interacting with the system and how the system treats them. So some of the inequalities that we see in health outcomes, even for genetic conditions, are about how they're interacting with the healthcare system, because the world does racialize them and does see them based on race. So this idea that you can standardize labels, I think, is probably not the question. The question is, what are you trying to measure? What are you trying to explain? What are you trying to study? And what is the appropriate dimension that you need to capture and the appropriate label that you need to talk about that dimension? And so sometimes that might be talking about race. Sometimes that might be talking about ethnicity. Sometimes it might be talking about this new wonderful thing that me and Divya are hoping for, which is a new reimagining of how you think about ancestry. But even when we say things like, oh, we don't use race, I think what I was saying was, if you say something like African and we never say white African, or we never say white Caribbean, or we never say, when we're saying this, we're actually talking about race. So we're being very flowery and we're saying that we're talking about ethnicity. And often we're talking about race because, as people have shown you that when we put people in Latino or when we put people in Asian, sometimes we're talking about hundreds of ethnic groups. So the label that you're using that you think you are talking about ethnicity, you're actually talking about racial groups. And so I think it's just an honesty about what dimension are you talking about, what are you using about, and why are you using that label that you're doing. And I don't think there's enough of that. I don't think there's enough conversation about why am I using this label? Why am I thinking about this dimension? Because sometimes when you do that, you realize that you don't need the label or the dimension. And so going through that process actually is what is more beneficial than the standardizing, is actually the thought process about why am I calling a group this way and why am I using the group in this way? What impact will that have and how will that be interpreted? So I've picked up a few things, but hopefully that's kind of where my stance is anyway. I'm happy with any label as long as it's not offensive, as long as people can explain why they're using it. Yeah.
Anybody else want to come in on that one? I suppose I'm just thinking, just sort of And I'll move on about that label thing. And I'm thinking about Anika, Our Future Health, and how, sort of if we leap forward in 20 years' time when we've got all this data and someone's sort of having on a whatever the equivalent of Zoom is then saying, why didn't they do this? I mean, what, and sort of trying to think, put ourselves in that position about with hindsight, so, but that data would have been so useful if they just classified people in this particular way. So yes, any thoughts about that? And Anika, how much of a headache is it causing Our Future Health how to sort this out for the future?
Yeah, it's a great question, and I don't know if I necessarily have the answer for that. But we are, I guess, just in terms of labeling or just sort of the categories that we have at the moment with that sort of data, we break it down at quite a granular level, which is brilliant. I mean, I don't have it to hand at the moment, but I guess all the categories that you can possibly think about or think of, we do have them as part of as a sort of part of the program, so people can identify how it sits best with them. So I guess we are, I'm not saying that it's the best, but it is quite detailed in that sense that we do have quite a lot of categories, but we are constantly looking at this, and I think we're actually looking at it right now to sort of see, are there any gaps, should we be doing anything better, and we'll continue to do this and work with researchers and others on this. So yeah, it's a work in progress, but we do have a lot of categories right now, which was really great for me to see when I joined the organization.
Great. Okay, so I'm going to go back to Mida's question. So I did a little sidestep there. So she had one for Segun as well. So African Americans don't represent genetic diversity back in continental Africa. Can this be extrapolated to African and other diverse populations in the UK? And what implications might this have for healthcare outcomes?
Okay, so just to emphasize that again, African Americans don't represent Africa. So Africa has about 3,000 ethnic groups. About 5 billion people living in Africa are speaking 2,100 languages. If you look at London, for example, or you look at some part of the US, most people that migrate to that side are mostly people from West Africa, from Nigeria, just like in one region. So if you use data from those individuals and say, oh, this is Africa, so you've left behind so many ethnic groups, you left behind so many genetic variants that will be very, very important. So you cannot just say this is African. And the reason why people do that is because this is where we have the money. Thanks to UK Biobank, we have funding to generate data like UK Biobank, 500,000 people. Thanks to all of us, all of us in the US also having 1 million people. So people want to capitalize on this database alone because it has African, and not really going back to Africa and get every different ethnic group within Africa. I think all the initiative, all the biobank are very, very important. And they are doing all their best, particularly feature heads, to capture the African. But we need to remember that African is much more than those people that are living in the UK. We need to go to Africa and get a sample from those individuals.
Anybody else want to come in on that? Extrapolation of African American data. Great. Okay, so Anika, I've got a couple of questions for you. So one from Funmi Adenubi, who says, do you have interpreters available for those with limited English? And then Sarah Haywood has asked, do you have sign language interpreters available for people?
Yeah, great. Thank you, Sarah. So just to answer the second question, it's actually ongoing at the moment at the organization. So we are currently investigating BSL interpreting services and sort of assets and videos and whatever that might look like at the moment. So it's sort of a live project at the moment. So we are hoping to have that soon, but not at the moment, but it is very much on the agenda, and there's a project team working on that. So that is definitely to come. And to answer the earlier question, and it's also one of the first questions I asked when I joined the organization. So at the moment, we do not have interpreted sort of translation services. And the reason behind that is because if you think about, so I presented earlier the journey, the participant journey for people that join our Future Health. And it wouldn't just be that we translate the letter or whatever else it might be. It's actually that we have to think about the whole journey, and think about all the languages that we might want to offer this in. Then it turns into a lot of costs. For example, our clinicians would then need to be trained or be able to speak certain languages, so we can't just offer one part of it in a sort of a different language. It would have to be throughout the whole process, and because of that, it makes it more complicated. So it's not something that we have said no to, but it just because of the complications around it, we're continuing to have conversations about it, and hopefully we may be able to offer something in the future. But as it stands at the moment, we do not, and that's the reason why we're really focused on making sure that our information is as simplified as possible, to make sure that more communities can sort of understand what we're doing and how we're doing it.
Great, thanks. So good luck trying to to sort that out. Yeah, these things sort of, there's many layers to it, aren't there? It's sort of, you think it's quite simple, and then it's like an onion. You think, oh no, you've got to deal with that part too.
Yeah, it was way more complex than I thought it would be, but yes.
Yeah. So a question for Divya. Is there any prospect of changing the course race categorizations in the actual census rather than trying to compensate for the limitations of this data? Or is that a dangerous can of worms to open up in the current political climate?
Yeah, great question. So in the US, they reconsider the race categories every 10 years. And that happened actually quite recently. I think it must have been 2 years ago. And it was great because they added a new coarse race category for Middle Eastern and North African, individuals, which broke that out from white entirely, which I think is something that should have happened a long time ago. I think they actually considered it in 1997, but decided not to implement it at that time. So it's great that 20 years later they managed to do it. So yes, there's definitely effort that goes towards resolving these coarse race categories. But actually, I think the fact is that in many health systems, the data is actually collected at a quite granular level. And sometimes when it's released, it's then coarsified. And so I actually think often the raw data has the information that we as researchers would really enjoy using and analyzing. And so I think it is kind of up to health systems to disclose more of that information for us to use. To your point about the political climate, it's quite interesting when in past presentations of this work, people have come up to me to say, okay, like, yes, it could be good for downstream computational researchers to have access to this data, but for several racial and ethnic minorities, it's a matter of safety to not disclose what group you belong to. And I think that is an important qualification here, that yes, like this more is more type of mentality doesn't really, it kind of breaks down in certain groups. So I think that is a good thing to be thinking about. But yeah, I think my takeaway from this work is that this data exists, and that to the extent that it's safe to do so, we should make it publicly available.
I could see lots of nodding from Sasha while you were saying that, and I wondered if you wanted to come in. Is it similar than in the UK? I'm trying to think when filling in the census, whenever it was.
Yeah, it has changed a couple of times, our census, so I think there is that as well. I think it was something that maybe I didn't explain well enough, because there was another question in there, I think from Phil, about self-reported and what impact that has on the data. So I think there is also something, I guess, that Divya is saying in there about actually what scientists use from the data is different from how you collect the data. And so when I think about exclusion or inclusion from a group, using census course categories to recruit can exclude people based on kind of what Divya said. So if you put, there was nowhere for Middle Eastern people. And so actually, if we're using that for recruitment, then as Segun said, rubbish in, rubbish out, there are people who are already excluded based on the categories that you use to recruit people. And then that's the only data that scientists then have to work on. So then the data becomes not generalizable to certain populations because they were never included from the way that you grouped them. Then you might do really well at grouping them and you might have lots of data and people have been really granular about how they describe themselves so that everybody feels included and everyone can become involved. But then the scientists themselves then can impute groups based on the data. So they're not using the granular things that you used to identify yourself or the things that were ticked on a form. They're inferring that from the data itself and creating their own groups. So then part of my conversation about, and then when does that build in an exclusion or an inclusion? That's about what the scientists are doing with the actual data. And then the way you share data determines, again, how you repackage it and share it and how you repackage it and publish it. And you might recourseify it in order to do that. Or there might be different governance reasons why you can't share the data in its raw form. So it's actually really complex. And that's probably why I was nodding a lot.
Yeah. The other thing I wanted to add was even on the subject of self-identified race, there have been some papers that show that if you collect race by paper or by phone or by iPad, you get very different races as a result. And so even like the method of race data collection has an impact. And I feel like some of those details aren't documented too. And so it's difficult to really understand what you're getting downstream.
Shanmugam, do you want to come in?
Yeah, just a tiny addition is that for scientists, it all depends on what you want to use the data for. People self-identify themselves as there could be anything, but if you really want the ancestry, sometimes we infer that from there. What is this person ancestry genetically? So we check that. We also check also in terms of sex or gender. People can identify themselves the way they want to be identified, but we also check what is this person's sex biologically, which might be different from what they told us. So it's all about what the study is all about.
Yes, and I think in the UK census, the religion section is sometimes an area where people like to put sort of more humorous things in the free form. From memory, I think it was Jedi from was a thing once. One thought, oh yeah, that'd be really funny. But yeah. Anyway, moving on. So I think there was one question. Let me just refind it. Where I think someone was concerned. It was sort of at the end of their question about whether it's from someone who's anonymous and saying that I think that ethnicity collection has not been standardized across healthcare institutions. Once this is sorted, there'll be clearer information on diversity. Well, we've sort of gone into that a bit already. But she says also healthcare professionals may have concerns about asking about ethnicity and, for fear of appearing racist in some way, perhaps. So I was going to say, Sasha, do you want to come in on that first from your experience
Yes.
at the coalface?
Absolutely. So I think there are two things there. So one is the hot potato. So sometimes is a bit of an excuse. And then the other thing is that sometimes that is the reality. And it's often a reality based on the fact that sometimes people don't know why they're asking the question. So actually, if they're challenged about why they're being asked, that then becomes a difficult conversation. And I know that there are genetic professionals who don't understand how the information is going to be used from when they've asked it in the clinic to how it's actually going to be used on a report or to do any type of genetic studies. And so then it does become kind of quite difficult. I think so. I do training with genetic counselors, kind of cross-cultural communication training, because as that slide that Segun showed, London is a really diverse place, the UK is a really diverse place. And so actually these sometimes are conversations just talking about culture and ethnicity are ones that people need extra skills to be able to manage. And so sometimes we do talk about that, and actually just humility, really understanding why you're asking a question, being able to explain that makes things so much easier for clinicians. And if you don't have a reason to ask the question, then maybe you shouldn't be asking the question. So sometimes the difficulty is that you're asking because habitually we're obsessed with filling in boxes. And sometimes maybe that question doesn't need to be asked at that way or at that stage. But we're being asked to do it and then we're not doing anything with the data. So there is something about, when do we need to be collecting the data and having the conversation? And often if it's not in the right place, it puts clinicians in a very difficult spot, because they don't have really good reasons for why they're actually asking these questions. Sometimes they don't even believe that anything really valuable is going to be done with the information once they've collected it. And so that kind of challenge also makes it really difficult for clinicians to have the conversation.
Segun, I wonder if you wanted to come in on this one as well, and if that from your experience both in the UK and in different African countries.
No, it's easier when you ask in Africa. People don't, you don't really. I didn't see myself as black until I moved to the UK. You understand what I mean? So it's not really a concern. Everyone is black. So it's when you move to and you see many other ancestries. Oh, this is I'm different. I'm different. But if you ask people in Uganda whether they are from different ethnic groups, it's not really an issue. Yeah. So I think I agree entirely with what Sasha was saying.
Great. Okay. So then I think there's quite a few things about the different categories. But Philandra has asked, she apologizes for asking so many questions. Don't apologize. They're very, very welcome. She says, what about unconscious biases or systemic pressures that influence how clinicians record symptoms or diagnoses in patients from racially or culturally diverse communities? How might this affect the accuracy and fairness of genomic data sets? I'm probably looking at Sasha again. Sorry, Sasha. I'm going to be coming to you first a lot.
That's okay. I think we have a well-established understanding of how racial biases are fed into medical training, into the way that we talk about symptoms and diagnoses, the way that people are offered medication or not offered medication. So all of those things, absolutely, for the whole life cycle of being involved in a healthcare system in a country like the UK or like the US, we absolutely know that these things do have an impact. And so what that means is that then it has an impact kind of, as I said, on their outcomes. So even though people might have the same genetic condition, the same inherited cancer, actually their outcomes can be quite different, kind of based on these inequalities that are built into the system. So I guess once again, that kind of leads back to my conversation about getting clinicians more comfortable with recognizing their own biases, recognizing the stereotypes, being more humble about the questions they ask and being inquisitive and all of those things, because I do think that they do have an impact on health. Did I quite answer the question? Was there something else in that question rather than agreeing with it?
No, I think that was okay.
Yeah.
Did anybody else want to come in on that one? If not, I'll move on to a question for Divya. So from someone who says, overworked healthcare professionals are increasingly using AI to transcribe their conversations with patients. Is it possible that certain biases and distortions are being introduced even at that stage? I realize that AI is getting better and better at capturing diverse types of speech and audio, but it's not perfect. Should we be relying on it so much for transcripts?
Yeah, it is actually, it's a little bit alarming to me how quickly these tools have been adopted at the bedside in terms of transcribing ambient speech in patient-provider communication. I started in machine learning for healthcare around 2017, and I kind of I think I would have never have imagined just the widespread deployment of AI in this way. In this year. So I agree with your concern and I echo it. I think that there are still issues with this. There are researchers from UC Berkeley who have demonstrated how using machine translation with non-English speech can get the prescription amounts wrong, can get the prescriptions incorrect. These are serious mistakes to be making when transcribing speech into clinical notes. And so, yeah, I think that there are kind of open issues with this. I think it goes back to something I was saying before about like the cost benefit trade-off is the value to the clinician in terms of addressing clinician burnout. How do we weigh that against some of these errors that we know are possible with AI systems? And then finally, I think it's kind of important to publish transparent evaluations of these systems on diverse speech. I think that that's something that I'd like to see more of. So yeah, I think reasonable cause for concern.
Yeah, I think so, especially, when it's going to be, something so serious as prescription amounts that could, seriously, have serious implications for the patient, lead to medical negligence claims if on the sort of litigation side, so burnout versus, medical negligence, and never mind the poor patient who may be made very poorly.
The other thing I forgot to mention was when I speak with clinicians, sometimes they talk about writing down clinical notes as part of clinical thinking. And so I do think automating some of this process of transcribing the interaction between the patient and provider automatically into a note is removing some of that opportunity to synthesize some of the information. So I think that's another thing we have to reason about losing. Sorry, that was my last thought.
That's okay. Right. So someone has asked, if self-declared ethnicity is not granular enough, and even a risk for some groups, should the focus be on genomic methods to look at ancestry? So should we make the genomics do the work for us here, I suppose? I don't know. Who wants to go first on that one? Shall I pick on you again, Sasha? Sorry.
Yeah, you can do. Absolutely. I feel as though if genetic ancestry is the thing that you need, then using genetics to do that is the best way to do that. I just feel as though, depending on how mixed your population is, you need statistics in order to make those groups clean. And what that means is that people who don't fit within the group, regardless of how you've chosen to define it, might not make it into the group. I don't know if I'm making a very, I don't know if I'm being, I feel like it's quite complicated to get that across, that there are quite, even though it's science and it's supposed to be objective, there are quite arbitrary limitations about what you use to define who is in a particular cluster and defined one ancestry and who is in a different cluster. So there are some scientific methods that can do that comparison without clustering. And sometimes the scientific method requires this clustering. So even though you've used genomic ancestry, you still haven't accommodated for the fact that genomic ancestry can be quite blurred. Does that make sense? So it's not a foolproof plan always, depending on the type of science that you're doing.
Yeah.
I think that's
I think Shagum's coming in there to
Segun will help me more.
Okay, just a little addition is that it's easier to say Segun is African. I'm African, of course. My dad African, my mom African, West Africa. It's easier. How about people like President Barack Obama? The mom is different from the dad. For example, dad is from Kenya, and the mom is she's white. So genetically, if you want to identify that person is mixed. They are mixed race. If you allow me, Sasha, to use the word race, it's not only African. They also have the component of white European. So I think if you are doing in genetic study, we like to use. I like to classify people based on what genetic is saying. Well, you cannot. For example, if I happen to maybe marry a white lady, and my children are mixed race, and in your category in school you put Africa, European. You're missing out. They're missing out because you have to be able to put appropriately where they belong. If they don't want to identify as African, it's fine. If they want to identify as something else, maybe white European, it's also fine because they are half.